In this video, we describe how to dissect the extensive blood supply of the abdomen. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. The GI tract is redundantly supplied with blood, whose supply is exquisitely regulated by the autonomic nervous system. Let's start the dissection of the blood supply of the abdominal cavity by dissecting the tributaries of the celiac trunk and the superior and the inferior mesenteric arteries. However, before we actually start showing you the dissection images, let's describe briefly the arteries we will see arising from the aorta. The main goal of today's dissection is to demonstrate the three unpaired arteries from which smaller arteries travel to the intestines and to the abdominal organs. These are the celiac trunk, the superior mesenteric artery, often abbreviated SMA, and the inferior mesenteric artery, abbreviated IMA. If you recall your embryology, the celiac trunk will serve the foregut, the SMA will serve the midgut, and the IMA will serve the hindgut. From the aorta, we will also have paired visceral arteries, and these are named for the abdominal organs they supply. These arteries are the suprarenal, the renal, and the gonadal, the arteries that supply the ovaries or testis. We also have paired parietal arteries, arteries that go to the body walls. These include the inferior phrenic arteries, the subcostal, and the forelumbar arteries. Finally, the aorta will terminate by dividing into the right and left common iliac artery and one single median sacral artery. Please realize that no one expects you to remember all these arteries simply by looking at the aorta. But as you proceed through the dissection, you'll become more familiar with the arteries and they will make more sense to you, and ultimately you'll be able to recall them from memory. In the previous dissection video, we observed a similar image and described the various structures listed here. Moving from left to right, we mentioned the gallbladder, the liver, the lesser omentum, the stomach, and the first part of the duodenum. Finally, we described the greater omentum. Also, we mentioned that the lesser omentum consisted of two separate ligaments. The one between the liver and the first part of the duodenum included the hepatoduodenal ligament, and it helped form the entryway into the lesser sac. Indeed, the hepatoduodenal ligament helps form the anterior wall of the lesser sac, which we entered by the epiploic foramen. The goal now is to use scissor technique to carefully begin removing the hepatoduodenal ligament without injuring the structures that are housed within the ligament. Working carefully, we start to separate the layers of the hepatoduodenal ligament until on its lateral border appears a cylindrical structure, the bile duct. Continue using scissor technique until the structures of the porta hepatis appear, shown in the next view. Here, we have stripped away most of the hepatoduodenal ligament to reveal the three principal components found within its layers. First, as already mentioned, we identify the bile duct, forming the lateral border of the ligament, and now more extensively demonstrated. Second, we see the blood vessel, and by noting the thickness of its walls, we can tell it is an artery, the hepatic artery proper. The last structure of this tripartite region is the portal vein. The bile duct, the hepatic artery proper, and the portal vein make up the porta hepatis, the gateway into the liver. Now note a string-like material on the outside of the arteries. This is not debris, but rather it is the autonomic nerves which are piggybacking onto the arteries to reach their final destinations. Indeed, Throughout the arterial tree of the abdominal organs, you will see this occurring over and over again. The arteries are all encased by abundant layers of autonomic nerves. Once again, return to the remaining lesser omentum and start using scissor technique to remove all of it. You have to use care, but by now you should be aware that the lesser omentum contains blood vessels that serve the stomach, duodenum, liver, and gallbladder. Having removed the anterior wall of the lesser sac, we can now enter this space and find the arteries and veins of the region. First, however, note that the veins shown here were partially colorized. This is because they were quite delicate in this particular specimen, and many were inadvertently removed during the dissection of the lesser omentum. We normally say that if you know the arteries of a region, you know the veins, because generally they are arranged next to each corresponding vessel, and so it is in this region. I do want to point out the esophagus in this dissection, and also the esophageal veins. These veins are of significant clinical relevance. The inferior one-third of the esophagus drains to the portal circulation, whereas the upper one-third drains to the intercostal veins, and the middle one-third can drain in either direction. The reason this pearl of wisdom is important is that in portal hypertension, of which you will learn more later on, the venous return from the lower one-third of the esophagus will be impeded, and these veins can become esophageal varices. If left untreated, they can rupture and lead to vomiting of bright red blood. Sometimes patients can enter shock. At this point in the dissection, it is expedient to remove all these small veins from the field. Having entered the lesser sac, orient yourself with the different glands that are visible and labeled. Understand that the pancreas is a retroperitoneal organ and not part of the lesser sac. The reason it is shown here is that the parietal peritoneum has also been removed in this dissection. We have now reached the level of the celiac trunk, one of three main unpaired arteries of the abdominal aorta. The celiac trunk is a major branch of the abdominal aorta that emanates from it immediately below the diaphragm. Here, we show it completely dissected and clean. The three branches from the celiac trunk include the left gastric artery, the common hepatic artery, and the splenic artery. Accompanying the splenic artery is a splenic vein. You can always tell the vein because it is straight, whereas the artery will be tortuous to accommodate the movement of the spleen. You can also see that there is a large mass of nerve tissue surrounding the trunk. This mass of tissue is called the celiac ganglion, or in layman's term, the solar plexus. From this ganglion, both parasympathetic and sympathetic fibers are distributed to the abdominal viscera. The presence of this ganglia accounts for the nausea that may occur after being struck in this region. The celiac trunk is set to provide arterial blood supply to the foregut, including lower esophagus, spleen, the stomach, duodenum, gallbladder, and liver. We previously saw the left gastric and the splenic arteries. Let's now see where the common hepatic artery, one of the three main branches of the celiac trunk, delivers its blood supply. We see in this specimen that the common hepatic artery divides into the hepatic artery proper and the gastroduodenal. We will trace the gastroduodenal later, but now let's look at the hepatic artery proper and see what it gives rise to. The right gastric artery, a small branch that travels through the lesser curvature of the stomach, and then the hepatic artery proper divides into the right hepatic artery and the left hepatic artery. Finally, we can just make out a branch from the right hepatic artery to the gallbladder, the cystic artery. Although this is the most common pattern for the celiac trunk circulation, Be aware that numerous variations exist, and you will see many in a lifetime of exploration. Having traced the arteries, let's now move to the biliary tree, which we first identified in the first step of this dissection. Emerging from the liver, we identify the common hepatic duct, which is connected to the gallbladder by the cystic duct, and then continues onto the duodenum as the bile duct. Remember, bile travels from the liver to the gallbladder, where it is stored until needed. Then it is released into the bile duct. What is not shown here, however, is how the common hepatic duct forms from two distinct ducts. But for this, we need to do a bit more dissection of the liver, as shown in the next image. Using a scalpel, we cut a wedge of liver and remove the wedge to expose the origins of the hepatic ducts. Now shown in the slide. We can make out the right hepatic duct and the left hepatic duct, joining to form the common hepatic duct, which is joined by the cystic down to form the bile duct. In the image, we can also trace the arteries of the hepatic artery proper, now labeled. We can see that in this example, the hepatic artery proper divides into the right hepatic artery and into the cystic artery, but does not give rise to the left hepatic artery. Rather, the left hepatic artery appears to be arising from an inferior location, and a subsequent dissection revealed that the artery arose from the superior mesenteric artery. This is an uncommon variant of the hepatic blood supply. We now need to trace the arteries that arise from the gastroduodenal artery, one of the terminal branches of the common hepatic. Look at where the artery goes, posterior to the first part of the duodenum. File this bit of wisdom away. Peptic ulcers are most frequently found in the posterior wall of the first part of the duodenum. If they were to go untreated and erode away the posterior wall of the duodenum, it would be the gastroduodenal artery which would be damaged by the leaking stomach acids, and the likely reason that the patient would have a massive hemorrhage. Indeed, peptic ulcer hemorrhages can still kill the patient because of this important anatomical relationship of the gastroduodenal artery to the back of the first part of the duodenum. Next, using scissor technique, we separate the greater omentum from the greater curvature of the stomach. What we see now is that the gastroduodenal artery divides just after entering the greater omentum. Its left division will travel along the greater curvature of the stomach as the right gastromental artery. It will anastomose with the left gastromental. We will see this anastomosis shortly. The right branch of the gastroduodenal becomes the anterior pancreatico-duodenal arch. It will supply the second part of the duodenum and also the head of the pancreas. The next step in the dissection is to reflect the stomach superiorly with the gastromental artery and the greater omentum still attached. And after reflecting the stomach and greater omentum, we can observe the transverse colon, loops of small intestines, and the cecum. The fatty-looking area is actually the peritoneum. It is covering the retroperitoneal organs, including blood vessels, we need to dissect free. The membrane from which the transverse colon appears to be suspended to the posterior abdominal wall is called the transverse mesocolon. At this point, start using scissor technique to remove the peritoneum and punch through the transverse mesocolon to again reach the lesser sac. We have again reached the lesser sac, this time from behind the transverse colon. Removal of the peritoneum exposed the pancreas. Before describing the vessels, make sure you identify the reflected stomach, the pancreas, and the spleen. Again, note the right gastromental artery on the greater margin of the stomach. Observe the splenic artery. You notice the artery because of its tortuous appearance, distinguishing it from the corresponding splenic vein that is straight. In general, a prominent artery will arise from the splenic, the dorsal pancreatic artery, that travels through the center of the pancreas, supplying it with blood. In addition, small branches from the splenic artery travel to the pancreas and help supply it with blood. However, these branches are quite small and were not preserved in this dissection. Following the splenic artery towards the spleen, note a branch emerging from it and traveling to the stomach. This is the left gastromental artery. Finally, short branches from the splenic artery, the short gastric arteries, leave to supply the fundus of the stomach. These branches must be ligated during a procedure known as Nissen fundoplication, in which the fundus of the stomach is used to wrap around the esophagus and create a new sphincter to treat reflux disease. Now you might wonder how the stomach survives if these short arteries of the fundus are ligated. The point to remember here is that the stomach receives redundant blood supply to its surface. Hence, when we state that the short gastrics supply the fundus, it is not meant to imply that they are the sole arteries that do so. Think redundancy when you think blood supply of the stomach. Return to the area where the superior mesenteric artery and vein are located and finish removing all of the peritoneum using scissor technique. After carefully scraping away the peritoneum, an image similar to what is being shown should emerge on your cadaver. As before, we find the superior mesenteric artery and note that it's encased by autonomic nerve fibers. The superior mesenteric vein is just to the right of the artery. Indeed, in the abdomen, veins will generally be located to the right of their corresponding arteries. From the left side of the superior mesenteric artery, various numbers of jejunal ileal branches will emerge. These supply the jejunum and ileum, hence their names. From the right side of the superior mesenteric artery, various arteries emerge. Having reflected the transverse colon, we can see the middle colic artery turning upwards. Realize that it typically points inferiorly in the anatomic position. Next, we find the right colic and then the ileocolic arteries. Although, as I mentioned previously, expect variations, and I do mean expect variations. In a separate dissection, the SMA and superior mesenteric veins are also demonstrated. Pretty much the arterial tree is shown as in the previous image. In this image, however, the area posterior to the SMA and SNV were clean of all peritoneum to demonstrate its structure, the third part of the duodenum. Now think of from where does the SMA arise? The answer is the aorta. Now continue your thoughts. What is the organ field served by the SMA? The answer is the small intestines to large intestines. Now think of what would happen if you laid on your back. The angle formed between the aorta and the SMA may also lead to a nutcracker compression phenomenon of the third part of the duodenum. While this is not the classical form of the nutcracker syndrome that you will learn about shortly, nevertheless it is real and may be associated with gastrointestinal obstruction. It is possible to continue cleaning the arterial tree free of veins, autonomic nerves, and mesentery as was done in this image. We can again review the superior mesenteric artery, the superior mesenteric vein, the jejunal ileal branches coming off the left side of the artery, and then the named arteries, the middle colic artery, the right colic artery, the ileocolic artery, and finally, note the continuation of the SMA. If you follow the ileocolic artery to the cecum, as shown in the zoom image of the artery, and if your cadaver still has its appendix, you can dissect the ileocolic artery to the one singular appendicular artery, found within the mesoappendix. Because only one artery supplies the appendix, in cases where it is occluded, the appendix can easily necrose and become a source of infection. The only treatment at this time becomes surgical intervention. One last feature of the superior mesenteric artery is how it provides blood to the jejunum and ileum. We mentioned earlier that it's nearly impossible to tell the difference between the two components of the small intestines with the naked eye. This remains true except if you dissect out the blood supply to the two regions. In the isolated small bowels, simply use scissors technique to demonstrate the specific arterial tree to the individual small bowel components as is shown in the image. If you take care when removing the mesentery, it is possible to demonstrate that the arterial arcades of the jejunum and the vasa recta, as shown in the slide, vary from those serving the ileum. As you can see, the jejunum exhibits short arterial arcades and long vasa recta, whereas the ileum is characterized by having long arterial arcades and short vasa recta. And yes, these structures will not always look like you probably just saw them appear in a standardized textbook. The last artery we need to find is the inferior mesenteric artery, the IMA. To do this, simply take all the small intestines and reflect them superiorly until you're certain you can palpate the aortic bifurcation, or the knuckle, as some people call it. It will feel like a large bump. Then, use scissor technique to remove the peritoneum and go superiorly. Realize that the inferior mesenteric artery will send a branch to the left colic flexure. Hence, at some point, while separating the peritoneum, a branch of the vessel you're tracing will make a turn superiorly. Having used care in patients to remove the peritoneum, this is what the arterial supply to the remaining aspects of the large intestines looks like. Trace again the transverse colon, becoming the descending colon at the left colic flexure, then becoming the sigmoid colon. Now let's look at the arteries. We start with the inferior mesenteric artery that gives rise to the ascending branch of the left colic artery. Note how this artery curves upwards towards the left colic flexure. Here, it anastomoses with the marginal artery, a branch of the middle colic artery from the SMA. This is considered a watershed area with respect to the blood supply of the large intestine, in that the transverse colon is served by the SMA, but the descending colon is supplied by the IMA. At the interface where the two arteries supply the colon, the area is most susceptible to ischemic attack. Returning to the IMA, we see that it continues as a superior rectal artery and sigmoidal branches to the sigmoid colon. This now concludes the description of the arteries that supply the alimentary tract, from the lower third of the esophagus to the sigmoid colon and upper rectum. In a subsequent video, we will present the other vessels that originate from the aorta and are principally involved with supplying blood to organs not involved in the alimentary canal. In addition, we must now consider the venous return of the alimentary canal. The venous return is straightforward and is by way of the tributaries of the portal vein that accompany the arteries arising from the AMA and SMA. Here, for example, we can see some of the veins that accompany arteries arising from the IMA. Here are the corresponding veins to the arteries that arise from the SMA. The superior mesenteric vein is clear, as are some of the veins that accompany the jejunal ileal arteries. But if you look closely, each artery is paralleled by corresponding vein. For example, the right colic vein and the ileocolic vein. All these veins are part of the portal system of veins because they originate at a capillary bed and will end up within the capillary beds of the liver. Ultimately, All of the arterial blood that is delivered to the intestines returns to the portal vein and then to the liver. Here again we see the portal vein within the porta hepatis. Portal venous return is from the splenic, superior mesenteric, and inferior mesenteric. Now imagine what will happen if the liver is diseased and prevents the return of venous return from the abdomen. This condition is called portal hypertension, can be deadly if not treated, and will be discussed elsewhere in your training. This now concludes this introductory dissection on the blood supply of the abdomen.